please don't leave here saying that coffee is good for you, only for the liver, only if you've been diagnosed to have muscle D, on a light note. So I want to move away from the complication of muscle D and look at another possible complication, which is what's killing our patients, which is heart failure, and see how we can circumvent this. Like Dr. Murunga had said, that we are very good in actually discovering all these new drugs. But we find our complications are still presenting. There's very little decrease in your morbidity and mortality. So today's talk is focused on that. My disclosure slide is that this is a Roche-sponsored talk. I apologize, I forgot that slide. So why are we talking about this? It's because, like we have said, all the presenters have talked about for the last 2.5 days, is that the burden of type 2 diabetes is increasing, and you can see globally. The problem we are having is Africa is actually triple what we are seeing in the rest of the country. And diabetes is actually responsible for about 6.7 million deaths as far as 2021, and it's actually increasing. But what's killing our patients? It's actually cardiovascular disease, isn't it? And you know, there's been a lot of fuss of why do we keep talking about diabetes? It's because if you look at the number of admissions in hospital, 1 out of 5 actually has diabetes. And what is the problem? It's because of the issue of cardiac disease. So when you have your hyperglycemia with insulin resistance, you have production of your advanced glycation products, which affect your mitochondrial energetics. Then you have production of the reactive oxygen species, causing your inflammation and endothelial dysfunction. And this also causes your sympathetic and your RAS activation and results in your diabetic cardiomyopathy or your ischemic cardiomyopathy, which then results in heart failure. Now, when you look at all the CV complications, heart failure is actually one of the earliest to occur in our diabetes patients, as high as 14%. But what's this burden with regards to patients with diabetes? It's affecting up to 22% of our patients with diabetes. And of this, you find there's an increased incidence of heart failure in our patients with diabetes compared to those without diabetes. And women were in trouble. There's actually a 4-fold increase in heart failure if you're a female who has diabetes compared to a 2-fold increase in heart failure when it comes to men. And you can see it's actually a highest 5-year risk ratio of death. And there's an increased tendency to develop heart failure and ultimately mortality as you progress. And what is this relating to when we come to economic sense? When you look at hospitalization for heart failure, if you have diabetes, actually you have a 33% greater risk. When it comes to length of stay in hospital, our diabetic patients stay longer compared to those without diabetes. And then, of course, there's a 3-fold increased risk of death. So we know we have a problem. Our patients are dying, and one of the things that they're dying of is because of the complication of heart failure, right? So when it comes to risk stratifying, you want to identify the problem and then see what we can be able to do. We find that actually diabetes is actually a stage A form of heart failure. So if you have other complications like hypertension, coronary artery disease, you've been subjected to cardiotoxic drugs, then you already have stage A heart failure. So you already know if you're diabetic, you're considered to have stage A. A large number of our diabetic patients already have some structural heart disease, but they are asymptomatic. So our patients fall in stage A and stage B, and by the time you're developing symptoms or you have refractory heart failure, you're in trouble. So I've shown you where diabetes falls, right? So is there a solution? Yes, there is. And you've heard about the talk even from yesterday, where the drugs like your SGLT2 inhibitors have shown that there's reduced morbidity, reduced hospitalization for heart failure. So the risk is you have diabetes. What is killing you, what's causing morbidity is a heart failure. Do you have therapy? Yes, you do. So where is the problem? The problem is we're diagnosing it very late. So what if we actually preempted this problem and thought, I know what my patient has. I know that they're already at risk of heart failure. What if I risk stratify them and take into account things like hypertension, obesity, which we've been talking about, AFib, increased age, obstructive sleep apnea, of having diabetes for more than 10 years. These are the people who are likely to suffer from heart failure. So can we be able to predict who's likely to develop that cardiovascular condition? And that's why we came up with a molecule called brain natriuretic peptide. So this was first discovered actually in a pig's brain, hence the name brain natriuretic peptide. And then it was subsequently discovered in high concentration in your cardiac tissues. But the problem is when they went to the lab, we found that it had a very short half-life. And so then they looked at the inactive terminal molecule called the N-terminal proBNP, and we found it had a longer half-life of 90 to 120 minutes. So it would be a better molecule to look at if you're going to try and see if we can predict heart failure. Now, it starts off as a molecule that's 108 amino acids, then broken down finally to 76 peptide molecule. But what is of note is it's secreted in response to the stretch in the ventricles when you have volume overload. So you're starting to see how this is important. What are the effects of this BNP? It stimulates the release of your ANP and your BNP, and they're found to have diuretic, natriuretic, and antihypertensive effects. And also what's very important is it's protective against your detrimental fibrosis, which occurs as a result of your prolonged inflammation. So we're starting to think, could this be the molecule that can predict someone who's at high risk of heart failure? But like with all molecules, you have to think, are there some limitations? So they are. In terms of anyone with chronic kidney disease, you have to think twice, and you have to see the interpretation now with the lab on how do we account for someone who has chronic kidney disease. We've also found that apparently lean patients tend to have a higher BNP, up to 3 times compared to your obese counterparts who have diabetes. And then any patient with AFib, and you know AFib actually is found to be one of the triggers for heart failure. So take that into account when you're interpreting this. So you want to see if this molecule, you're a researcher, you want to see if this molecule is actually going to predict, based on your risk stratification, you've identified patients at risk. And so what they did was they looked at and they worked out, they found an NT-proBNP level of more than 125 as the likelihood that this is what will help predict someone is at risk of heart failure. Then looked at if anyone has evidence of structural heart disease. And when they looked at the progression, by the time you're getting structural changes, the NT-proBNP was actually high. So that's one way of predicting that someone could have heart failure. So let's bring it down now to on the ground. And what they did was took about 5,000 patients who had had a recent coronary event, okay? You will worry about the ethics of this study, but what they did was they wanted to see, they measured your NT-proBNP at baseline, and then again at 24 weeks, that's 6 months, and followed these patients up for about a period of 26 months. Now, if you haven't had a history of heart failure, you look back as far back as 6 months before the patient presented with heart failure, you could see that exponential rise, okay? So that by the time they're getting a heart failure, presenting with heart failure, these levels were already high. So you should have asked, I mean, why didn't they act upon it? But what's the evidence that if you actually act on an elevated NT-proBNP, the patient is going to get better? And you can see it remained persistently elevated if you had had a history of heart failure. So we're starting to see it can predict for as far back as 6 months before you present. Now, what we generally use for most of our patients, it's cheap, it's cost-effective, is A1C. Now, can A1C be able to help you predict if you're at risk of heart failure? And we'll see the evidence. So they took about 544 patients, and they measured the NT-proBNP and your HbA1c at baseline, and they repeated it again after 1 year, and followed up these patients. What we found was, when it regards to NT-proBNP, it was significant for all-cause mortality, hospitalization from heart failure, and any cardiac hospitalization. As opposed to A1C, actually there was no correlation. So having an A1C does not outrightly predict that you're going to be at risk of heart failure. What about albuminuria? Most of the cardiologists are talking and saying that this could be actually a risk factor for cardiac events, but is it important for patients at risk of heart failure? Now what they did, they got about 1,000 patients and measured the NT-proBNP and albuminuria and drew their graphs. So what they found is with your NT-proBNP, When it is less than 125, not very useful, but when it is quite elevated above 125, you can see that it can actually predict a cardiac event. The discriminatory significant factor was quite important. But when you added USCR, there's actually no benefit. So for cardiac event, like your myocardial infarction, yes, albuminuria. For heart failure, perhaps not as useful. Now you say we're living in a low middle income country, so why don't we use the risk scores? So you have your risk scores like your score and your ESC. What they look at is things like your age, do you have any comorbids, what's your total cholesterol level, smoking status, and using that you can, and you put in the parameters of your patient, it can predict where your patient has heart failure. So why don't you do a head-to-head comparison, looking at whether someone's NT-proBNP is less than 125 or more than 125 against the score and the ESC risk stratification, because you're using against what people generally use. And what they found, when you looked at the NT-proBNP, it was actually more significant in predicting a cardiac event. So the farther away you are from the line, it means it's more sensitive and more specific. And you'll find that actually NT-proBNP was more significant in terms of the discriminatory significant factor compared to your score and your ESC scoring system. So they are useful, but NT-proBNP is actually better. So let's see if it correlates. Now, do you see this group that is non-classifiable based on your risk scoring system? You know, sometimes the problem with these risk scoring systems, they tell you, like say, your patient has to be between the ages of 40 or 75. So what happens to the patients who are younger or the patients who are older? And that's a problem we've been having with the risk scoring systems. So look at this where up to 17% could not be classified. When you measured it against your NT-proBNP, can you see how it was actually missing quite a number of the patients? When you look at what is regarded as moderate or high or very high, look at the level of your NT-proBNP. So we think we could be under-diagnosing or misclassifying some of our patients, and it was actually worse with the ESC classification. So look at its ability to predict your CV death over the overall cohort when you're comparing without cardiovascular disease or without cardiovascular disease. You can see how NT-proBNP performs very well compared to the rest of the scoring systems. I'm not saying throw the baby out with the bathwater. I'm just saying that this molecule could be useful alongside your risk stratification scoring systems. And if you're going to use one, use score compared to your ESC. Now, when you look at these graphs, this tells you its ability to predict cardiovascular death or all-cause death. Now look at this ESC. It's all jumbled up, so you can't see someone who is at moderate or who is at very high risk or moderate risk. So as opposed to, look at NT-proBNP. If your risk is moderate versus high versus very high, you can be able to tell because it's numbers, and numbers don't lie. Look lower down at all-cause death. You can see the way the lines merge, so you can't really tell where to put the patient. But look at NT-proBNP. It shows you whether your risk is moderate, high, or very high. So you can tell the clear distinction and know how you're going to be able to interpret. Similar with this slide. So let's bring it down to that's the lab, right? And you want to see against, I've shown you against A1C, I've shown you against albuminuria. So we've also looked at the risk scoring system. Let's actually see if it's useful when you bring it to the patients. At the end of the day, you want to see its utility. So they did the Pontiac study. This was purely for research purposes. Because you see, I've told you risk stratify. And they picked patients who had type 2 diabetes, more than 18 years with no history of cardiac disease. But they purely did NT-proBNP for all these patients. Patients also had hypertension. And they divided them into a control group where the patients were followed up at 4 care units and an intensified group. And the concept is if you have, and you measure your NT-proBNP and it's elevated, follow these patients. Give them maximum RAS blockade. You are titrating according to your NT-proBNP levels and see whether if you're using an NT-proBNP to guide your management, there's actually going to be a difference. And you can see there was a 65% risk reduction in hospitalization or death if you actually titrated your RAS blockers based on your NT-proBNP. So the Pontiac study was very useful. Let's bring it closer to home. The sub-analysis of your Canvas study where they use canagliflozin for your patients with type 2 diabetes with atherosclerotic cardiovascular disease. Now, one of the things we do is we give SGLT2 inhibitors because we know there's benefit. And how do you know it's actually giving that benefit? You prescribe, but your patient always asks you, Daktari, for how long will I take it? And then on top of that, how do I know if I'm getting better? So we actually have a way of showing them, and this is by quantification. And when they use this drug, the canagliflozin, for up to a year, they found your NT-proBNP was actually reduced by 11% compared to the group that was not on the canagliflozin. And this was significant for reducing your overall 3-point MACE and hospitalization. So you have a way of actually predicting. Another way was in your DECLARE-TIMI study. What it found was in the patients who are given the dapagliflozin, you wanted to see whether it's important to monitor and see do you need to uptitrate a dose or not, and whether it is useful. And they found the people who had higher tertile quartile ranges with regards to your raised NT-proBNP. If you gave DAPA, there's a better reduction in your NT-proBNP and reduced risk of your hospitalization. So the higher it is, even better for the patient because you can be able to demonstrate an even higher reduction of even up to 17% in reducing your risk. So you will see that there's actually evidence. This was also seen in your EMPA-REG trial, where it reduced your NT-proBNP by 13%. So I'm showing you quantitatively, you can show your patients that we can actually document evidence of improvement as we give you this medication. And it's actually helping us also in our obese patients that the more obese you are, the higher your NT-proBNP. So that's another way of actually stratifying your patients. So let's bring it home, right? Now this is a time when you can wake up, stop scrolling on your phones, and then just listen. If there's one thing you're going to take from this, it is this slide. I mean, I've simplified it. So stop yawning, drink some water, and then listen. So you consider your type 2 diabetes patient to have stage A heart failure, right? You do your proBNP. If it is normal, please leave the patient. Don't go repeating after every 3 to 6 months. The recommendation is after 1 year. But if you find it elevated, how about you now confirm? You'll do your imaging, you'll do your echo, your ECG, and then if you have confirmed, then you can be able to manage the patient. But remember, when it comes to now follow-up, we are using this molecule for two things. Number one, to help diagnose the heart failure, because look at majority of our diabetic patients have heart failure with preserved ejection fraction, isn't it? So if you do your echo, is it going to give you much? Most of the time we've said echo normal, you say don't worry, come after 6 months. And that's why we are missing our patients. So help diagnose. Number two, monitor. So do you see the utility of this particular molecule? I really hope someone say yes. I've talked, Bana, for 20 minutes. Thank you. So what have I said? Heart failure is one of the commonest complications that you'll see in your patients with diabetes. And there's effective treatment. It's demonstrated, documented. You have your SGLT2, you have your GLP-1, right? But now we are saying we have a molecule that can not only help us predict the risk of heart failure, but we're going to help reduce the morbidity and overall mortality. So if there's one question I know you're likely to ask me, let me preempt the cost. But let me put this question to you, because I know you even said yes. Just think about this. How much money does a diabetic patient who's admitted for heart failure spend? Based on one, the bed they're occupying, number two, time lost away from work, from school, and the amount of medication that they're going to be on when they eventually go home, the frequent follow-ups, as opposed to you did this test, you started treatment early, you prevented hospitalization. Have I pleaded my case and won? I say yes. And with that, I'm done.